Hello, everyone. We'll give it just a moment for any additional folks that are joining, and then we will begin. Okay. Thank you, everyone, for joining today. My name is Stuart Portman, and I serve as Executive Director of the Medical Assistance Plans Division at the Department of Community Health, or DCH. DCH is the lead agency for Georgia's newly approved Rural Health Transformation Program submission. Today's webinar is the start of our conversation together and is intended to provide some introductory background on our rural health transformation efforts in Georgia, with a specific focus on transforming for a sustainable health system. All participants today in this webinar are in listen-only mode, but DCH welcomes follow-up questions or requests for more detailed discussions. Today's webinar is intended to be an introduction to the payment model discussions that will take several months for us to continue to design and years in terms of the development. This is a great opportunity, but it's not something that is made and then presented. It is something that is developed collaboratively with stakeholders across the state. And so this is an initial conversation, and there will definitely be more to come. As some initial background, to make sure everyone's on the same page, on July 4th, 2025, HR 1, which is commonly referred to as the One Big Beautiful Bill Act, was signed into law. This bill created a significant opportunity for the state of Georgia to apply for federal funds under a new rural health transformation program. States could apply for a portion of $10 billion per year for 5 years. $5 billion per year would be evenly distributed to all states that apply, and all 50 states did apply. And $5 billion were distributed based on a methodology determined by the Secretary of the U.S. Department of Health and Human Services. Georgia submitted its rural health transformation application in the fall of 2025, with year one funding announced by CMS at the very end of December. We are thrilled that Georgia was awarded over $218 million for the first year, which is the 7th highest award of any state. We believe the 29 projects included in our application will be instrumental in transforming health in rural Georgia. And I want to begin here with the 5 initiatives behind our Rural Health Transformation Program, which is also known as the Georgia Rural Enhancement and Transformation of Health, or Great Health Program. Each of these initiatives is in support of a Great Health Program goal. The first initiative is transforming for a sustainable health system. Under this initiative, the state will prepare rural health facilities and providers for the future participation in the CMS AHEAD model, which stands for the Achieving Healthcare Efficiency Through Accountable Design. As part of this initiative, the state will dedicate resources to work with hospitals and healthcare leaders to assess readiness, identify gaps, and provide important technical support for lasting participation in reforms. We'll be coming back to this initiative and the AHEAD model and value-based care more broadly in more detail shortly. The second initiative is strengthening the continuum of care. This initiative includes strategies such as improving behavioral health, enhancing infrastructure related to emergency response, and improving public health initiatives. We're implementing strategies to increase access and fill gaps in a continuum of care across life stages, settings, and needs. The third initiative is connecting to care to improve healthcare access. Here, the state is seeking to expand rural residents' access to care, making sure they have more opportunities to access primary care, specialty care, dental care, and behavioral health care. We will leverage innovation, technology, and targeted investments to advance this initiative. Fourth, we will focus on growing a highly skilled healthcare workforce. We want to increase the number of healthcare providers working in rural Georgia, and this initiative includes strategies to recruit, retain, and incentivize healthcare professionals in rural Georgia. Lastly, our fifth initiative is leveraging technology for healthcare innovation. This initiative advances technology-driven solutions to enhance care delivery and create a modern, secure, and patient-centered healthcare ecosystem. Each of these initiatives involves various strategies and projects to help achieve the overall goals of the Great Health Program. And you can see a complete list of the 29 projects on our Great Health Program website, which you can find at the DCH website. Full information is listed there about our project and the narrative that was submitted to CMS for review. The 5 initiatives I just reviewed will help us achieve our overall Great Health vision, which is that rural populations will be healthier, they'll live longer, and enjoy a higher quality of life in the communities that they love. Rural places will have access to local, high quality, and effective care, and rural hospitals will be financially sustainable. And rural progress will be supported by new systems, technology, and a genuine focus on patients and their families. As previously mentioned, our first Great Health Program initiative, which is transforming for a sustainable health system, has one overall strategy. That strategy is the North Star for this entire proposal, and it is to create an on-ramp for Georgia to participate in a value-based care model that prioritizes rural hospital stabilization, preventative care for patients, and local control of healthcare. This is currently envisioned to be advanced through the CMS base, the Centers for Medicare and Medicaid Services base, Achieving Healthcare Efficiency Through Accountable Design, or AHEAD model. This model is a total cost of care model that aims to do the following: curb the growth of healthcare costs while maintaining quality, strengthen primary care, improve the health of the population through expanding preventative care and addressing whole person needs, and importantly, aligning Medicaid, Medicare, and commercial payers to reduce fragmentation and administrative burden. Georgia intends to, and has received the green light to officially align our Great Health Program and the AHEAD model to create a formal pre-implementation period prior to the start of the AHEAD model. During this pre-implementation period, the state will fund assessments for eligible hospitals who opt in and will invest in a hospital's service delivery and technological capacity to support success in the AHEAD model. Additionally, should the eligible hospitals agree to formally participate in the AHEAD model after the pre-implementation period ends, risk mitigation funds will be made available for 2 years to assist in real-time learning of total cost of care budgeting. This means we will make participating hospitals whole if they experience financial loss when attempting to meet all program requirements. That is a first of its kind approach to value-based care and an incredible opportunity for Georgia. When there are typically value-based care models in effect, they don't have this sort of risk mitigation available. It is solely because we have aligned our value-based care approach with the Rural Health Transformation Program dollars that allows us to have this amazing opportunity to provide real-world learning and a focus on a sustainable future. Please note that participation in this pre-implementation period is voluntary, as is the decision to participate in the AHEAD model itself. But we are hopeful and believe that many of our rural hospitals will choose to join us in transforming how care is delivered across the state. Today, DCH wanted to outline 2 of the major financial components of the program design of the AHEAD model: the hospital global budgeting and total cost of care. I want to discuss those 2 payment models, which really are at the heart of the Georgia AHEAD strategy, and discuss them in a bit more detail. First, it's important to recognize that while these 2 models would be implemented together to reinforce the system's transformation, they really serve distinct purposes. The total cost of care approach is broader in scope. Its focus is on coordinating and managing the full continuum of care a patient receives, not just within a hospital, but across all providers and settings within a given catchment area. It's about tracking and improving the overall patient journey, which can lead to more holistic and effective care. In contrast, the hospital global budget model is more targeted. Here, the emphasis is on financial sustainability and stability and care improvement within the boundaries of a hospital. This model sets, this model sets a fixed annual budget to support hospitals especially in rural areas, helping them control costs and shift away from relying solely on service volume. A key feature of both models is that they are designed to include all payers: Medicare fee-for-service, Medicare Advantage, Medicaid fee-for-service, Medicaid managed care, and commercial insurers. Including all of these payers within that catchment area and within that hospital budgeting will help align incentives and provide a unified approach across Georgia's healthcare system, as well as give more certainty and, as mentioned previously, more local control. We will start on the left side of the screen with the hospital global budgeting next. For global budgets, a fixed budget is established prospectively for the year. Payments are distributed consistently, and incentives are aligned to promote efficiency and maintain high-quality care, rather than just increasing service volume. The state will define what's included under each hospital's global budget. For example, grouping together a hospital and its affiliated rural health clinic under a single budget to maximize system alignment. The state may also define any services or populations that will be carved out and remain on a separate payment basis. Should quality measures be met, there's also the potential for bonus payments, depending on how the model develops and from the input we receive. Moving to the right side, under the total cost of care model, the state defines which providers and services are included, and then sets an expected per-patient benchmark for annual spending. Payments to providers generally remain in a fee-for-service space, but the key is the annual settle-up process. Through that process, actual costs are reconciled against targets. This provides an opportunity for shared savings should the provider perform under the targeted amount, and this introduces the potential for losses for spending above that targeted amount in an effort to drive towards accountability and responsibility for the patients that we serve. Ultimately, both of these approaches, hospital global budgets and total cost of care, are designed to align incentives and create that financial predictability and really give providers new tools to succeed in value-based care with the goal of supporting stability, improvement, and, as stated, local control here in Georgia. Both of these are separate yet necessary and mandatory components of the model that we would choose to advance. CMS is planning to open the AHEAD model to 2 new states in 2026, with performance starting in either 2028 or 2029, based on their public statements. Georgia is reviewing the application based on previous cohorts of this model, which have included approximately 5 states in the past, to make sure that we can meet all anticipated requirements. Those requirements are state accountability targets, which include clear investments in the total cost of care and primary care system, a hospital global budgeting methodology that has to involve Medicaid, Medicare, and commercial payers, broader primary care transformation, which has to involve Medicaid alternative payment models or patient-centered medical homes, with a focus on behavioral health integration and enhanced coordination of care, and a state population health accountability plan, which emphasizes preventative care and chronic disease prevention, and 2 state policies from a broad list that promote choice and competition in healthcare markets. While we are basing this off of past releases, we expect there to be some modifications in the new Notice of Funding Opportunity that comes out from CMS in the near future, and we will evaluate based off of the new notice. As you can see, there are a lot of policy and programmatic decisions that still need to be made as we move towards this transformation. But we are excited as a state to move towards those opportunities for long-term stability. And we see this model as offering a lot of opportunity to our rural health systems. In the months to come, DCH will engage with providers and other partners to make decisions on how to best move forward, and we do welcome your broad input. As stated, a major element of the AHEAD model is the requirement for the adoption and implementation of a Medicaid primary care alternative payment model, or APM. This level of primary care engagement is necessary in order to be successful in evaluating the total cost of care of individuals within the catchment area. Georgia must implement a Medicaid primary care APM by the beginning of performance year 1, which the state would intend to be 2029, if one does not already exist. This can be through a patient-centered medical home, a PCMH model, or through some other value-based arrangement that emphasizes meaningful care coordination, health-related social needs, and integration of behavioral health and specialty care. General considerations for the design and implementation of an APM frequently include identifying the proposed authority, whether it's regulatory, legislative, or waiver actions, developing eligibility criteria, such as whether and how to include federally qualified health centers and rural health clinics, determining the payment model, such as shared savings or population-based payments, and the use of outcomes measures, and the timeline for implementation. As Georgia develops its approach to meeting the Medicaid primary care APM requirement, we are heavily weighing the PCMH option. There are several outstanding decisions, though, for the PCMH option, which we are still working through. Like the development of an alternative payment model, the PCMH option will include a lot of general considerations, such as the payment structure to primary care physicians, the use of certified electronic health record systems, and the specific quality measures that need to be included. It's also worth noting that the inclusion of independent physician practices, federally qualified health centers, certified community behavioral health clinics, rural health clinics, and other primary care providers can raise unique challenges. Specifically, how do you blend complex payment changes necessary for a HED with existing payment systems for those providers in the primary care space? We will have an opportunity to be the first state to address this in a meaningful way, and we look forward to the dialogue seeking to solve this. When other states have encountered this situation, many of them have tried, but perhaps backed away. We see this as an opportunity for the state in our alignment effort here to actually engage meaningfully and bring in those providers because they all share the same goal. In all of these situations, we will continue to engage with our hospital and provider stakeholders to make sure the model design works for Georgia's diverse rural settings. We understand that this is a very big transformation, and even in this initial conversation, shared a lot of broad details. We intend to offer a lot of support along the way, including through some of our submitted Great Health projects. We can look quickly at what hospitals can expect as we prepare for the AHEAD model participation. This timeline slide assumes that Georgia will begin the first AHEAD performance year in 2029, which gives us a couple of years of pre-implementation to really prepare. To highlight, in 2026, there are several key readiness activities. Letters of intent have been distributed to rural hospitals, and interested hospitals will be able to submit signed letters back to us at DCH, and thank you to the number of you that have already signed them. We also anticipate that CMS will release and award the AHEAD Cohort 4 Notice of Funding Opportunity, sometime in the earlier part of this year. We will also provide both financial and technology assessments for all participating hospitals in the pre-implementation period. And year one of service delivery and technology improvement funds will be released for the hospitals to determine how to best improve their service delivery or technological capabilities. Our anticipated pre-implementation window will go from 2027 through the end of 2028. The key activities that will happen here will be that DCH will conduct further hospital and provider recruitment. There will have to be comprehensive hospital assessments that are completed. There will be hospital electronic medical record grants that will be awarded to support upgraded technology and alignment so that this is about a broader cohesive technological strategy, not just baseline EMR capabilities. There will be enhancements for consumer engagement because consumer engagement is a vital component of successful value-based care models, especially when speaking to population health needs. And a second year of service delivery and technology improvement funds will be released to all participating hospitals in the pre-implementation period. Additionally, in performance year one, which is again anticipated to start in 2029, The Medicaid APMs, likely or potentially to include patient-centered medical homes, will be fully implemented. We also will have to have the Medicaid hospital global budgets go into effect, and the total cost of care target calculations will begin. Throughout this journey, and it's a meaningful journey, but it's significant, Georgia's readiness plan is designed to help both hospitals and providers succeed in the AHEAD model. And that would include technical support, resources for assessments, and financial investments in both technology and care delivery. This is intended to be a truly transformative process, and success does rest on strong partnership at every stage. I want to thank everyone for joining and for your time and commitment to rural health in Georgia. Our hospitals are the backbones of our communities, and together we will work to transform care, strengthen our systems, and improve health outcomes across the state. I'll note that you really should reach out to the department if you have questions or would like to discuss your hospital's particular readiness or needs, or if you're a provider that has additional questions related to total cost of care or patient-centered medical homes. In all situations, you can email Great Health at dch.ga.gov, and our team will respond promptly. These slides and this webinar will be posted to our website following this presentation, and again, will be available for any additional follow-up conversations. So I want to thank everyone for your time today. I know we said that this is listen only, so if you have questions, you can feel free to send an email to thegreathealth@dch.ga.gov. If you are a hospital that received a letter of intent and have more specific questions, you can also respond to the email from me that you received regarding the letter of intent. And we look forward, myself and our team, to helping answer any additional questions as we work to move forward and advance care for the state. Thank you again for your time, and we hope everyone has a great rest of your day.